So we're moving on now to hepatobiliary. I guess it will adopt a sort of similar sort of format in terms of this is a group discussion, and sort of throw it to the floor. Is there anything specific? There were some questions earlier about what we should be adding either to the PQIP database in terms of data collection. Is there anything that we should be collecting? Is there anything specific that that we could be using this data for in terms of outcomes?
Hi, Craig Lance, Institute of World Free. I think just in terms of a success story, really, we've used the PQIP for 3 different projects. It's been really central to reinvigorating an ERAS process, which had been dormant for a couple of years. What was interesting about the way the data was presented is, as an HPB cohort, it wasn't very useful to us. So we were able to approach PQIP to ask for a separated hepatic surgery, pancreatic surgery, so then we could get to the nuts and bolts of, we obviously have a separate ERAS protocol for liver resection as opposed to pancreatic resection. And so that's the first point. The second point is that we've been able to use the data to look at things to do with risk scoring specific to liver resection, and look at the impact of complications on length of stay. We weren't able to show that there was any risk score that was very good, but we've been allowed to then submit an application to look at national data to see if we can look at national data to see in a larger data set if we can use an existing risk score or develop one of our own risk scores. But part of that in terms of missing data is there's some key elements to developing a liver-specific risk score that would be missing from the PQIP data set, things like bilirubin, things like that, which you would suggest would be important in that kind of risk score. So that's something that we need to work on and highlight to PQIP.
Okay. Any other comments?
Can I?
Yeah, go.
Craig, I think we discussed it before, and I'm full agreement with you. Perhaps I can make a couple of observations as well on top of what you say. The first one refers to what I just heard about the attitude of surgeons to accept evidence, for instance. I think it's an important aspect because it shouldn't be underestimated. Surgeons tend to use the evidence they wish to use, unlike oncologists, unlike anesthetists perhaps, which are much more compliant with the level of evidence. I'll give you an example. I am a pancreatic and a hepatobiliary surgeon, and years ago we published a meta-analysis on pancreatic gastrostomy versus pancreatic jejunostomy. It must have been a flavor of the month, because during those 2 years, 7 meta-analyses and systematic reviews were published. All of them, including ours, suggest that pancreatic gastrostomy was associated with a better outcome and lower complication rate and shorter hospital stay, but equal mortality. This hasn't been sufficient for the pancreatic surgeons around the country or around Europe or the world, in fact, to change their attitude. If you have an oncology trial comparing capecitabine with gemcitabine, for instance, be reassured that if one of them turns out to be a better treatment, the treatment will change overnight. So that is one consideration which we need to make when we deal with the impact of the PQIP results. They are not necessarily going to be accepted, adopted, and implemented. But there is one other consideration which might help. As I said before, I don't recall the surgical community, certainly not the HPB surgical community in our center, probably in many other centers, to engage in the design of this study. And this, if I may, controversial and provocative, if you like, it is an important aspect because most of the powerful studies in these days are from collaborative work. The vast majority of surgical studies now are multi-center, and most of them, in fact, use research collaborative groups. Now, if you want the surgeons to engage in this PQIP project, he needed to have some kind of reward. And I'm not saying necessarily an authorship on a paper, but has to be in some form, because otherwise it would be very difficult for them to digest, especially as this is true. I don't know who was the gentleman the colleague who labeled this as an anesthetic audit or an anesthetic study. It is true. It is perceived in the way. I've been very happy to engage with Craig and Marta at the Royal Free because I'm interested in it, and probably many other colleagues are. But we are losing and missing out on a vast majority of surgeons across the country which could engage if done in a different way. Craig, do you want to comment? Do you want to comment, Chris? Sorry.
May I interrupt? Sorry. I just heard what you said. So I'm afraid I'm going to have to disagree with you. So we had representation from the Royal College of Surgeons, from most of the surgical specialist societies in our clinical reference group from the beginning of the study. We have 3 consultant and 3 trainee surgical leads now on the project team nationally. 2 of them are sitting on the stage with you. So we have a lot of surgical engagement in terms of the design of the study and the continued delivery of it. We've also said that everybody who is listed as a collaborator by their local principal investigator will be listed on future research publications in a collaborative model, just like they are in the report which has been published today and the report that was published last year. So there is that sort of tangible return on investment. The thing that we struggle with is that concept that this is an anaesthetic study, because the chief investigator is an anaesthetist. It's got the Royal College of Anaesthetists branding on it because they are helping to pay for it. And it is something that is quite difficult to overcome. Now, my view on it is that that has to come from local leadership, because we've kind of done what we can in terms of national leadership, in terms of having people like Derek Alderson on the stage today, people from surgical specialist societies helping us to design the data set, people like you standing on the stage now helping us move forward. But in terms of the sort of QI objectives, that has to come from locally. We can't, from the central team, dictate how local teams manage themselves. So that is a really difficult nut to crack. And we, when we bring new sites on board, we ask them to name a principal investigator and a surgical lead and a QI lead and a management lead. But how much engagement we get from all of those different leads in reality is something that it's very hard for us to police. I mean, we can't police it. So I don't quite, I'd be very, very keen to get new ideas about how we engage surgeons locally, and ownership of the data, and knowing that you can access the data both from local level and also the national data set if you apply for it might help. But I think things like this take time as well.
Well, Romani, I'm glad to hear that surgeons were part of the design. When I asked you earlier from the audience, I didn't get this answer, I didn't know that. And I'm equally glad to hear that the study was endorsed by the Royal College of Surgeons as well by the anaesthetists. But moving away from it, it is true, as you say, that there is a lack of local engagement from the surgical community, regardless of whoever endorsed the study. And that's what you probably want to tackle. So I'm just highlighting the fact that in many centers there is a lack of engagement with studies which perhaps are perceived, no matter how endorsed they are, as an anesthetic study. The NILA study was an example of it. So if you want to overcome that, I was trying to do it in a constructive way, not in a critical way or in a negative way.
Are forced on a lot of the medical structures are individual based, right from medical school and interview, and the whole career structure we work through is individually based. And I think the surgical career structure even more so than the anaesthetic side. And I think this switch in attitude to sort of do what have you done, what did you lead, what to this collaboration that we know is needed on this national scale is actually quite difficult. And I think just in my own department, this sort of national collaboration is over sort of local collaboration. We've got 15 anaesthetists in our department, and we don't have 5 or 6 of them looking at an individual project or problem. There's individual work and then national work, and this idea of collaboration on a local level just is really just alien to medicine in general. And I think the way we select and interview and everything that goes through reinforces an individual base, and then we get to where we are now, and we know we all need to work collaboratively, and then we're surprised when people don't want to engage in these collaborative structures. So I think something from the colleges and ourselves professionals, and what is important going all the way through them strata suddenly can't be switched on when you get to a senior national level. That's ingrained all the way through.
Can I perhaps move from this, because the purpose of this brainstorming was to have ideas, and from what you told me earlier, Ramani, is to identify variables, for instance, which could be captured and recorded. We are necessarily not. I don't know how many HPV specialists are in the audience. I mean, Chris, you are an expert in ERAS, correct? Because in your center, you are a great advocate and got great experience. Then we have the Royal Free in HPV. So, for instance, one thing which, when we had a kind of brainstorming meeting with my colleagues, and this is at the Royal Free, was whether there is a way to correlate, and whether it's already in the PQIP data set, a way to correlate ERAS with the experience through ERAS with an oncological outcome. Obviously, that requires a long-term follow-up. Our patients who are ERAS and they get discharged earlier, presumably with less complication at times, because that's one of the fundamentals of ERAS, are they associated with a better outcome? There is certainly evidence, for instance, that pancreatic resection patients who do not have a complication and recover quickly and quicker, they have chemotherapy sooner and they have a better long-term survival. Is it something which we could explore?
Yes, definitely. There's a lot of evidence, particularly for colorectal surgery, longer outcomes are better with ERAS. With our trial, we looked at 5-year outcomes. There was a significant improvement at 2 years with decreased mortality rates. Didn't quite become significant at 5 years, but I mean, you know, this is small numbers. It was only 90 patients, but I think definitely a chance to look at longer outcomes. It's almost certainly going to be there.
So we could have access to the national data set to explore.
I think we should, yeah, definitely.
Maybe an idea. Any ideas from the audience? Please.
I'm not a pancreatic surgeon, but Keith Roberts has done a lot of work in Birmingham around that fast-track surgery, about these patients that present with jaundice, CT showing a pancreatic lesion, and then being able to perform a Whipple's on them quickly. Now, clearly there are two things there. There is the quality of life side of it, because you'd assume that actually to have their surgery quicker and they recover from it, they have better quality of life, particularly when they're waiting for an operation. I just wonder whether you feel, as a pancreatic expert, whether there is any value in looking at something like that, to look at a national level, looking at patients having pancreatic surgery and looking at how long they've been waiting. I know when I spent time in the liver unit in Birmingham, the open and close rate was phenomenally high, and Keith's done a lot of good work around about trying to reduce that, and one way is by fast-track surgery.
Yeah, well, I know Keith has been doing all this work, and is effectively the shorter, the better. I mean, the sooner you take this patient to theatre, the better. I don't think there is any dispute on that or any doubt. We've equally tried to shorten the pathway at the free by implementing one-stop clinic, where our patients get seen in a surgical clinic, then on the same day have any further CT scan or any other form of staging they require, and see the anesthesia for preoperative assessment. I think, Marta, Gray, you may contradict me. I think it's about 70-75% compliance. So not all patients go through this pathway, but undoubtedly has reduced the pathway significantly by a number of days, I think by 12 days overall. And the same principle applies. The sooner you get the patient on the table, the better it is, I presume, for upper GI cancer as well. The difficulty, as you know, is not so much when the patient lands in the institute. The difficulty is when the patient gets referred to us from the periphery. And this is something which for us is extremely difficult to capture. In this sense, the PQIP study, which is a national and not just apply to tertiary referral centers, can have a massive impact, I think. What do you think, Chris?
I would agree, yeah. You've got to get patients in. Going back from some of the other sessions, well, certainly the last session, it was more about analgesia. We use a lot of epidurals in our institute for particularly liver resections, which is my main interest, but also pancreatic resections. I think something like PQIP would be a great, well, you could use this to compare certainly different analgesic modalities. Is anyone else using anything differently? Intrathecal morphine, I know Steve Wigmore's group up in Edinburgh are using a lot of wound catheters and tap blocks. There's, okay. For liver resections? Okay. And what sort of dose of morphine are you using? Okay. Okay. There was a great study from New Zealand where they used it sounded like they were having problems with epidurals on the ward, and so they moved to intrathecal morphine, and they got really impressive mobility rates, 100% independently mobile on post. Oh, okay. Right. Okay.
I think that there is also a difference between wound catheter and abdominal wall blockade, which is effectively what you do by inserting this catheter in the subperitoneal space. It's a completely different kind of analgesia. I'm a great advocate because we've been using it in some of our patients with phenomenal results. Martha and Craig, do you want to comment on that? Because we've been doing a lot of work on this and certainly trying to implement it directly. Can you have the microphone, please?
I think it's with the free, it seems. There's been a move away from epidurals at the free, actually, to intrathecal diamorphine up to 1 milligram. Obviously dependent on high dependency, intensive care postoperatively. As part of the enhanced recovery protocol, we've even widened that. So there's a move towards wound infiltration catheters. We have a big funding issue with that, and there's a big obstruction from finance in terms of the cost of those devices. The use of other abdominal trunk blocks like erectospinal blocks is also something which has come across from other surgical specialties within our trust and certainly in our interest. And use of nerve catheters as well, or catheters placed whenever you do a block. So those are all options, but I think generally spinals would be our recipe. I think there's a trial going on at the moment, which we hope will answer that question. We're doing a trial looking at epidurals versus intrathecal, and to see what the results of that will be, which I'm not sure where we're at with that, actually. I'm not sure of that.
And are you finding that you're getting better mobilization rates with that?
Yes. The reason it came from a body of work about 3 years ago, and actually 3 or 4 years ago, and we were able to show that there was no change in pain relief, or there wasn't a significant change in pain relief, but the other markers in terms of mobilization, length of time on inotropes, fluids, were all significantly different in the intrathecal group. So that's why there was kind of a general move towards it, and also the concern about the skill mix in the ward with management of epidurals, and epidurals coming out prematurely without kind of general discussion in terms of that was a perceived negative with the epidurals.
Yeah, I mean, I would have to agree. It is a problem how they're managed on the ward. I think it probably is the future, actually. I would have to agree.
Yep. Sorry. Yep.
So in Bristol, we've moved away from epidurals completely for hepatobiliary and using wound catheters and PCA, and we showed a cost saving with reduced HDU admission and use of vasopressors, and that's worked really well now. We're doing that for a couple of years. The other comment just about rapid pancreatic surgery, one of the main problems we've got is bed availability on high dependency. So actually we're seeing so many cancellations that we plan to do unstented pancreatic surgery, and then they end up being stented and delayed for that reason. And I wonder if that's something
that's an excellent problem, I'm afraid,
to look at, is number of cancellations before patients are getting surgery.
Thank you. Do you want to make a comment?
Would be a nice measure. Sorry.
Do you, what experience with pancreatic surgeons is that, do you feed at different times? What's your feeding policy in terms of enteral feeding?
It depends. It depends whether you're talking about a distal right or left side of pancreatectomy. For distal pancreatectomy and splenectomy, I guess the majority of surgeons in the country feed them early. with a pancreatic head resection, again, there are two types of reconstruction, as you know, pancreatic and again, slowly people come into ERAS. We are planning to implement an ERAS for pancreas. The great resistance, I have to say, I am resisting to it myself, is on pancreatic gastrostomy, with the fresh anastomosis in the back of the stomach, and the pancreas, which usually is a risk because you choose a pancreatic anastomosis, which is a higher risk of a leakage most of the time, unless you do routinely a pancreatic gastrostomy. It is difficult to get a surgeon to feed a patient earlier, because if there is a leakage, the leakage could be dramatic. So I think the pancreatic gastrostomy is very controversial, let's put it this way, for most. Pancreatic jejunostomy, slowly I think, is becoming more adopted in many centers, including ours. Any further questions? Or we can probably have a coffee then, call to the end. Oh, sorry.
No, that's fine. Thank you very much. That's fine. Thanks.